Welcome to the Athlete's First Performance Podcast, where two performance-minded physical therapists break down the evidence to improve overall health, movement, and performance for athletes and active individuals.
All right, welcome to episode 10 of the Athlete's First Performance Podcast. Today, we're going to be focusing on low back pain and the athletic population, particularly the younger athletes, anywhere from 12 to 18 or 19 years old. We're going to be touching on the differences between low back pain in the general population and low back pain in athletes, the various pathologies that you may see when examining an athlete with low back pain, and then we'll get into some management strategies as well. So, James, do you want to go ahead and get started? I guess we can just start with what are you seeing that's different between an athlete with low back pain versus a general population patient with low back pain?
Yeah, so I think the biggest thing is just making sure that we're screening these younger athletes, because the biggest thing that I'm seeing, and that we know in the research, is these younger athletes, especially athletes that are going through more of a growth spurt, they're more prone to stress fractures. So in terms of stress fractures in the back, we call that spondylolysis. So that's the biggest thing that comes into mind at the very beginning, especially with athletes that are involved in collision or contact sports such as football and wrestling, and then especially sports such as gymnastics, throwing athletes like baseball and javelin, things that require a lot of repetitive rotation along with repetitive and forceful extension. So that's really the biggest thing that comes into mind when dealing with younger athletes that have back pain, because that's something that we want to make sure that we can identify and screen out, and then ultimately refer for imaging if necessary. A lot of the other things that we can see in low back pain in general are more of that radiculopathy or radiating pain down the leg, and that can be in athletes or more of like a general population. So I think the biggest thing that we can focus on today is more of that stress fracture and that spondylolysis in these athletes.
Yeah, I think there's definitely differences, and one of the biggest differences, at least just preparing or maybe trying to utilize the evidence when you're seeing one of these patients, is there's just not a lot of evidence. Like there's not a lot of research on low back pain in athletes. And most of the stuff that I came up with, and I don't know about you, was from like 2009, 2010, 2011. There's a clinical commentary that was helpful that was a little bit more recent. But as far as like systematic reviews, and maybe I just missed them, there weren't a ton. But yeah, I think one of the things that I noticed as far as just differences, and I think me having seen quite a bit of low back pain in the general population, the evaluation process to me would be different. Obviously, the injuries that you're seeing are going to be different because like you said, mostly athletes are dealing with a repetitive use back injury, possibly also traumatic. But to me, the exam is different. So if I'm seeing somebody with low back pain that's sort of insidious with no real mechanism of injury, I'm doing a general movement screen, figuring out what positions hurt them, obviously dependent on if it's more acute or chronic. I have more experience with the chronic low back pain population. So it's a pretty general examination with a lot of treatment related to graded exposure. And it's not like, that treatment methodology would definitely work also with athletes. But from what I noticed, and this is kind of more in your wheelhouse with with some of the broader movement assessments like the SFMA, it's a lot about looking at the local area of injury, but also looking at the whole dynamic movement system, kind of what they would call the regional interdependence model. You do that. I feel like you have more experience than me. So is that a similar approach that you would take if you're looking at these patients?
Yeah, definitely. That's the first thing that I'll do. And we'll get a lot of information in the subjective exam. So before we get into the full movement assessment, subjective exam, some things that I really like to know are, is there any change is there a change in season or a change in sport? So have they started something new that they're practicing a lot? So maybe they just started baseball season, they're doing a lot more throwing or pitching than they're used to. My most recent patient that was dealing with this, she was a young gymnast. I think she was in 6th or 7th grade, and she was learning a new skill. So several times a week, she was learning some type of like back handspring. So that's repetitively loading that extension. And we know that makes sense, just like any type of injury or mechanism. If you're not used to it and you're loading it repetitively over a short period of time, we know that you're more prone to tissue breakdown, in this case, bony breakdown, without that full recovery. So we'll get a lot of information off of that subjective exam. But yeah, you're definitely right. Like I'll go through a standing SFMA, pay a lot of attention to their static or starting position, because a lot of times if we know that these younger athletes are more in that anterior pelvic tilt, kind of hanging on that lumbar extension or excessive lordosis, that's already setting them up for more of that bony. They're pretty much looking for that bony stability to try to create some more trunk control. So when that lumbar extension moment's definitely going to play a big role in that. And then I'll just take them down into breaking out their thoracic spine and their hips, because we know that if they're lacking hip extension or thoracic extension rotation, they're going to make that up somewhere from their lower back. And again, that's pretty much the mechanism of injury for these stress reactions or stress fractures.
When you have somebody that comes in, let's say they haven't been to a doctor and they haven't had any sort of major workup, and you find signs of a possible spondy, would you refer any of those patients? We know that sometimes imaging doesn't necessarily make a difference. And in this group included, obviously you want to rule out anything serious, and a spondylolisthesis would probably warrant a little bit more workup, particularly if there's neurologic symptoms. But with someone that comes in with that localized back pain, nothing radiating down, and all signs point to either just an extension-based low back pain or possibly a spondy, are you referring those patients, or are you going to go ahead and treat them conservatively?
Yeah, so I was suspecting a spondy just based off of her exam, super tight hamstrings. Like she wasn't able to like sit in class just because of the increase in tone in her lumbar paraspinals. And this was direct access. So this is when I was up in North Dakota. She came in direct access, and everything pointed to spondy. So I did refer her to a primary care, and she saw like 2 or 3 different doctors because they had mixed reviews. Her first doctor came back with a positive finding of a spondy, and then she saw like an actual ortho, and it was negative. So they just said, forget it. They didn't even go back to doctor, but we treated her like a spondy. She didn't have a back brace or anything. But yeah, I think it's good to make sure that you're not missing that, because sometimes, depends on what doctors you go to, they'll put the athletes in a brace for 2 to 3 months, and then they might increase like vitamin D just for bony growth and bone health, and they'll do repeated imaging. So usually x-ray is not as specific or sensitive. They'll go to like a CT scan, a SPECT scan, or an MRI for further imaging to get more direct or a little bit more specific with the views.
Yeah, no, I agree. I think it's hard though, because you have that fight that battle of like, I don't want to, refer and cry wolf and nothing's going on. You don't want to miss anything either. And if it comes back with a spondy, depending on the physician, the treatment's not going to be a whole lot different. You may just have a little bit more rest than you would if it was just a general, extension-based back pain. So it is kind of hard, but I would say, yeah, just being conservative is probably the way to go.
Yeah, and my biggest thing were her and her mom did not want to take time off of gymnastics, and she was also doing competitive cheer. So this was in the winter time, and they were doing a lot of travel cheer. So I wanted to have a little bit more backup in terms of like imaging, or the doctor saying, okay, you need to stop and hold off, because they weren't really buying into what I was saying. They were all for PT. They came to PT twice a week for a while, but her and her mom wanted to continue traveling, competing in this travel gymnastics and travel cheer, whatever they were doing. So that was my biggest thing, just getting the doctor on board to tell them, hey, you need to stop and take it easy and stick with PT for the time being.
Oh yeah, that's actually a good point. Sometimes you definitely need a little bit of kind of like a something to pull out just in case that they aren't compliant with everything that you're telling them. So one of the other things that going through this, there's different ways you're going to examine, right? So you're talking about the regional interdependence model. Now there's a few special tests that you can do depending on the presentation that the patient has. Obviously, if you have a flexion-based low back pain, particularly with neurologic symptoms, you may be thinking disc issue. So these tests aren't anything mind-blowing, the straight leg raise test or slump test. One of the things I did find interesting was that in one of the papers that I read was you might not see radicular symptoms in the younger population. Didn't really say why, but that's just something that I had never heard before. So I'll get your opinion on that in a second. But yeah, so with a disc herniation or someone with flexion-based low back pain, you're obviously going to do your nerve exam and maybe a straight leg raise and slump. When it comes to extension-based, there wasn't a whole lot of special tests to go through, which you don't necessarily, I feel like a spondy sort of just, stands out. But one of the tests they talked about was a single leg hyperextension test, which, it reproduces the typical mechanism of injury, but instead it was neither sensitive nor specific. So not very helpful. Is that something that you use, or is there anything else that you use as far as special tests go?
Yeah, there's a couple of things. Like if I'm suspecting this, I definitely want to find a position that recreates their familiar pain or that tightness. If we don't, then we're not doing our job, or it might be something else. But I'll start with 2 legs, just standing 2 legs, multi-segmental extension. And then if that doesn't reproduce it, then I'll go into that single leg to where they're loading that side a little bit more unilaterally. If that doesn't reproduce it, I'll try to go into like an extension rotation. So if you think about, if you're going to the left, you're pretty much just extending and rotating by sliding your left hand down the hamstring. So you're extending and rotating to that same side, pretty much just closing that whole side off. And if none of those 3 reproduce that same pain, then that might be changing what I'm thinking in terms of the spondy. So those are the big tests. Some people might also look at like a prone press up just to see that multi-segmental extension in an unloaded pattern, see how that does, or see how the patient feels with that. And then through fellowship, we went through a couple different tests. I call it like a shearing test, almost like the Sharps Purser test for the cervical spine. Is pretty much just, there's 3 different positions, but pretty much just trying to shear the levels of the lower lumbar spine. So we know it's most likely going to be like L5, S1, L4, L5, because those are the most mobile segments. So trying to shear those segments in sitting or standing to see if that reproduces any of their symptoms. Is there anything else that you have seen or done in this patient population to try to rule in and rule out?
No, I think if you just look at the risk factors or what the typical clinical presentation is, you kind of know. And I definitely agree, trying to reproduce their symptoms is important. And I would imagine one of the 3 things that you just said would do that. So, I always would start out with just lumbar range of motion and see what it looks like. And you're going to have someone that, if they have an issue such as a spondy or extension-based low back pain, they're probably going to have pain with that movement right away. And at that point, I don't need to provoke it anymore. But yeah, no, honestly, I don't do anything special. But that was just the thing with that single leg hyperextension test. It was the numbers aren't great, but it's you're reproducing the mechanism of injury to a degree. So I think it could still be useful. I don't necessarily think that if someone has back pain enough to where they're going to come in to the clinic and you can't reproduce it with like one of those 3 things, it's probably not extension, based on back pain. And I guess while we're on that topic, we're primarily talking about spondies and extension low back pain. I know I mentioned like a disc issue. I was listening to a course on MedBridge, and this sort of falls into the treatment-based classification system that we would use for general population low back pain that has good evidence behind it. This course was focused on athletes and diagnosed people, or I guess placed people into 3 categories. So they just didn't have the traction category, but it was like a flexion extension oriented low back pain. They did like a mobility / SI joint dysfunction low back pain category, and then a motor control category. Do you find these categories to still be useful in this population?
Yeah, I think it's definitely helpful for anything. It's just good to help put all the patient's symptoms and their objective exam in a category. It helps with that clinical reasoning.
And you answered it. Basically, you do use them to a degree. Obviously, kind of keeping anything in some sort of category helps lay out your plan. But I think this modification to the traditional treatment-based classification is helpful in that it's just a movement-based, like flexion extension-based, or a mobility issue or a motor control issue. But they are treated differently. And I can go through the way this course had said to treat it, and then we can decide what we think on it. But for a flexion-based issue, you're typically going to do an extension-based program. For an extension-based issue, you're not going to necessarily do a flexion-based program, but you're going to work on core stability and then just avoiding the painful positions for a little while. For a mobility issue, you could do your manipulations based on the clinical predictive rule. Any sort of mobility routine is fine too. And then for motor control, you're going to be doing motor control exercises. Now, the big thing that they had listed for all 3 categories was local motor control and regional interdependence, and that fell into every category that they listed for treatment. If we're getting beyond, for you, like beyond the extension-based program, or beyond the any sort of mobility stuff like manipulation, like that's clear. When you get into motor control, how do you define your program, if you would call it a motor control program? Like what exercise would you use, things like that?
Yeah, so I think that's a tricky situation because we all learn in school the so-called motor control exercises where you're laying on your back doing like TA draw-ins or trying to activate your multifidi. I think that's just confusing for the patient, and it's hard to get them to buy into that. I think about motor control as just moving well without that aberrant motion and just being able to control good positions. So if they're pretty low level, if we're thinking like that phase 1, like acute, just learning how to go through some of these, I'll start with just general things like planks, starting with like a push-up hold and a front plank, side planks, some things like dead bugs where you're holding an isometric trunk control and then moving your limbs. So that starts to look like a running position, squatting position. So just getting them ready for the basic fundamental movement patterns. And we know that they're going to be on the ground. So there's going to inherently be less stability focus on those positions and like prone, sideline, or supine, and then just gradually moving up into half kneeling, split squatting, and a standing position. So I think we need to move away from the specific TA and multifidi isolation movements and just starting them with easy movements on the ground, progressing up into standing, and then eventually loading them. And I know we'll probably get into this, but just loading them appropriately and making sure that they're ready for axial loading in their spine. Is there anything else that you do, or like what do you think in terms of motor control?
Yeah, well, the only thing, and I agree, like getting to the specifics is that down into the nitty gritty with the multifidus and transverse abdominis. I don't necessarily think that's necessary. Though a lot of the stuff that I read, particularly there's an article on the current concepts of core stabilization, but it was written in 2013, that placed a pretty big emphasis on trying to get you to use your TA or the multifidi. And you just can't say contract that muscle like you could tell someone to do a quad set. But I do think that when you're trying to control lumbar lordosis in these positions that you said how you progress them, which is what I would do, you have to give them some sort of external cue to get them to maintain the so-called neutral spine. And sometimes that could be that drawing in maneuver that you would associate with a transverse abdominis contraction or just a posterior pelvic tilt to a degree. So I would never educate it as like, we're going to use your transverse abdominis. We're going to use these little multifidi muscles to help stabilize your spine. But I will have them cue into like, can you contract and maintain a stable position with your spine while you do these things with your arms or your legs? Can you do some of that stuff in half kneeling or tall kneeling, half kneeling, standing, whatever? Obviously, in an athletic setting, you're not thinking about that at all. But I feel like it sort of isolates what you're looking for more than having them sort of do it, quote unquote, sloppily. That's a word. So yeah, I guess I wouldn't educate it as that, but I would do a core progression and have them let them feel the position of like full, like pelvic tilt, lumbar flex sort of position in a anterior tilt position, and then see if they can kind of find at least not even necessarily the middle ground, but just find something away from the end ranges of motion. And then can you hold that while you do other things?
No, yeah, I definitely like that. So it's get them into a bad position and then way overcorrect, and then find that middle ground. Yeah, that's perfect. Yeah, I definitely like that. And then one of the things in terms of like isometric, like trunk positioning, like planks or things like that, I'll just tell them squeeze your glutes, squeeze your butt. That pretty much helps correct that hip girdle pelvic positioning to get them out of excessive lordosis or flexion. So that's worked out pretty well for me.
Yeah, I think, and it's because I take such a general approach with low back pain, particularly chronic low back pain. I have had to sort of change a little bit of my biases when looking at the athletic population, because there are specific things. I think things that they're obviously asking more of their bodies within their sport. So there are specific things that they do need to cue in on. And sometimes, like if I'm going to have somebody do with low back pain that has an issue with bending forward to pick something off the ground, I'm not necessarily going to like coach them on how to do a proper deadlift. I mean, if it's something heavy, maybe, but if it's just like getting them desensitized to picking something off the ground, then I don't really care how they do it as long as it's graded and they're fine with it, because they're not going to deadlift a grocery bag every time they go pick something up. But for this population, getting them to cue in on certain muscle contractions like the glutes, or maybe just like bracing the core a little bit while they do these things, can really change what they feel when they're doing the exercise. And even just psychologically for that athlete, that will probably make it feel more like a workout, make it feel like they're doing something, which I think, as we know, will also have a pretty good effect on outcomes.
Yeah, definitely. Keeping them active, keeping them moving. That's the biggest thing. So they don't get deconditioned for 2 or 3 months, and then you're having to start all over again, pretty much just to get them in shape for their sport. So yeah, that definitely plays a big role. Another thing that I really, really like, because obviously you're not going to be able to squat these athletes heavy, or you're not going to be able to load them actually heavy, especially early on. Things like sleds for conditioning and strengthening are awesome. You're really not loading the spine at all, and you can get them moving, work on it, get their heart rate up, load that sled up, work on their leg strength, and that's inherently work on their trunk strength as well, just to be able to hold their positioning, working on running technique, all those things. So that's become one of my favorite things with athletes that have any type of low back pain, just working on the sled, pushing, pulling, lateral crossovers, all of those types of things have really, really been beneficial for the athletes that I've been working with.
Those are good ideas. Yeah. And that's a topic that probably isn't addressed very often, but you have an athlete that's, particularly if it's a spondy that was probably not been practicing or not been training at the level that they were training in. So you have to, before you can have them return to the sport, they need to have all the necessary attributes that the sport requires, and cardio is typically one of them. So yeah, I think that's a really good way to load the spine in a low impact manner, or just to load the body in a low impact manner. What are your thoughts on this? So obviously we've kind of talked about progressing through like supine, prone, sideline, all the way up to dynamic movements with core exercises. Are you using certain tests or markers or things to determine when progression can occur? And there is an article that we can talk about that was actually from 2020 that has a little bit of a framework, but what do you typically use, if anything?
So the biggest thing is just checking that extension intolerance. So making sure that their symptoms are going down with just normal daily activities. Like they're able to sit in class, they're able to walk around their house, go hang out with their friends, not playing sports, obviously, but their just overall resting pain is going down. Because a lot of the athletes initially, they come in just super, super tight. Like I said, their muscles are all bound up and they're just not comfortable. So making sure that just resting pain, that daily level of pain goes down. And then making sure that they're not getting that sharp or localized pain with like unloaded extensions, like in a prone press up, and then eventually loaded in standing with 2 or 1 legs, making sure that those symptoms are gradually decreasing. So those are pretty much the markers that I use, along with like if they're being followed by like an ortho or a doc, making sure that those repeated scans are improving. So those are the 2 big things that I look at in terms of progression, as well as like how well they're moving and how well they're tolerating our progressions that we talked about, just their local trunk positioning, and then getting more into their fundamental movements. And if they can do all that well, and their pain and their extension tolerance is all improving, that's when I know that we can start getting a little bit more aggressive with like plyometrics or running, just light things like that. Is there anything else that you like to use or assess for that proper progression?
No, I think, like you said, well, there's nothing great out there that says like this is what, like nothing like obviously like ACL rehab or something like that. It's to me, it's subjective based on what the patient says pain wise. Your qualitative analysis of how they're moving when they do the progression that you want them to do. Probably time, but it's like to have with the repeated scans. Yeah, if it heals perfectly, and most of them do, that's going to give you confidence and the athlete confidence. But it has been shown to where it doesn't necessarily like heal all the way, but the pain goes away, or the pain goes away, but it's not necessarily healed. So sometimes that can be an issue, but like any image, you're comparing it to the presentation of the patient. But yeah, I don't know. I mean, this article, it was called Rehab Considerations for Spondylolysis in the Youth Athlete. I think you call it spondylolysis. To each their own. I don't know what's right. Maybe you're right. But it came out in 2020, so it's relatively new, but it was a clinical commentary, which I tend to like just because they're applicable, but doesn't mean everything's correct. It divided the rehab into 3 phases, and the first phase was muscle activation in neutral positions, like you said, avoiding painful positions. Phase 2 was promoting extension and rotation, so trying to get them comfortable into some of those positions that initially were painful, and then working on like the global muscle system during dynamic movements. And then phase 3 is return to sport, and continue to pay attention to regional interdependence deficits. But the progression was what I was looking at. And like, we just talked about how we don't get too detailed with like TA or multifidi, but they used 2 tests. One was with using the biofeedback cuff, which we've probably seen, people have seen before, taught in school. I don't know if you've used it since school. I think I actually have. And I don't hate it just because it's kind of like a game for the patient, keeps them involved, but it definitely doesn't need to be as specific as we say it is. So they'll use that and have them move their extremities and see if they can maintain a particular like pressure. And then they'll do what they call the multifidi lift test, which the person will be prone and they will lift their arms up. And you have to get into the paper to get the exact process because I didn't write it down. But that's a qualitative assessment. There's no objective thing. So to say those are our criteria for progression is no better than us just saying like their pain's good and they're moving better. The other thing they said was repeated lumbar flexion and extension should be pain-free. And I think we would both agree with that, right?
Oh yeah, definitely. Definitely early on, you want to make sure that their pain, their range of motion, especially unloaded or just the body weight, definitely gets back to their baseline. And going back to that biofeedback, that prone test, do you ever use Sorensen holds? So that's one thing that I'm trying to get every athlete to be able to just hold a Sorensen hold at least 1 minute.
No, but I was about to say that because to progress into phase 2 on that paper, there was an endurance test, but it was not a Sorensen hold. I was about to ask you, like, and no, I haven't had. I mean, you could strap their legs to a table or hold them, I guess, but I haven't had like the perfect setup for that. But yeah, so those endurance tests is a whole different way to do it, and I think that is way more effective than using a blood pressure cuff. And that sounds like you would agree.
Yeah, and it's definitely a lot more stressful too, because then you're getting that whole posterior chain. You're getting your hamstrings, glutes, lumbar extensors, back extensors. So you're getting a little bit of everything there. And we know a lot of those trunk muscles are more that postural endurance. So that's what we need, especially for higher level athletes. They need to be able to control that. So that's something that I've started to use a lot more. GHG, reverse hypers, Sorensen holds, things like that. Even those like Roman chairs, those 45-degree back extensions, especially once they're later in those phases, getting strong posterior chain. I think all that's awesome.
Do you cue anything? Sorry, do you cue anything with those exercises? Like, do you have them avoid, like, for example, like the Roman chair? Do you have them avoid like severe hyperextension, even if it doesn't hurt? Are you having them do that? Are you having them do anything as far as pelvis related? Or you just say like, just do this movement?
I tell them to squeeze their butt, and then I don't like that excessive reversal. So going from flexion to that excessive hyperextension, pretty much just stopping them in that neutral position.
Gotcha.
Do you think there's a role or like there's a difference as they start getting into those later phases and even earlier in terms of mobility, like how you would treat a thrower versus more of a contact athlete like football or wrestling? Like, are there specific things?
Yeah, I mean, I think, and we kind of talked about, and I guess I didn't say this when we were talking about the history briefly, was like, it's super important for these people for you to really understand their sport. And if it's a repetitive movement, and you should be able, you need to understand like what other areas of the body could be adding stress to the lumbar spine. So one of the things that I read was like lack for a thrower, for like, we'll say a pitcher, lack of thoracic rotation and throwing arm external rotation will place more stress on the low back. So yeah, I think knowing those biomechanics and how they all apply would definitely make me treat someone that injured themselves, I guess we would say more, I don't know, because I guess you could say alignment is impact, but that's repetitive too. But I guess someone that does repetitive motion, like a thrower, for example, or maybe like a gymnast or a dancer, then I think you would treat them differently than someone who is just getting like blunt force to their spine over and over.
Mm-hmm. Yeah, I agree with the baseball player, right? We need to make sure that they have great mobility in those other segments. So it's like a top-down approach, making sure they have good shoulder, thoracic spine mobility. And then for those contact athletes, making sure they have that inherent like spinal stiffness that they can load and maintain a good position without getting bent back into that hyperextension, that loading. So one might be more of a range of motion and motor control deal, and the other one might be just inherent stiffness and trunk stability and strength there.
Yeah, no, that's a good point. And it's another thing with treatment, and we just kind of talk about flexibility, but one of the things that was noted a lot in the stuff that I read was that, flexibility can be an issue for some people in certain areas. And one of the things that they talked about was hamstring flexibility. A lot of patients present with tighter hamstrings, kind of like anterior pelvic tilt position. Are you stretching those things or how are you going about improving the mobility there?
Yeah, so that's an interesting thing. Did they get that like a spondy because of tight hamstrings, or are those tight hamstrings more of like that neurologic guarding? So I think in the way that I view it, that's more of that neurologic guarding. Um, that's just a response to the pain and the tone. But I do want to make sure that they get adequate hip mobility. So if they're living in like excessive lordosis, we do want to try to correct that as best as we can. So making sure that they're getting adequate hip extension and their straight leg raise at least like 70 degrees, making sure that they're not stuck at like 30 or 40, as long as they didn't go through like a super quick growth spurt. But yeah, I think I'm not going to be hammering the hamstrings to stretch them out, maybe working a little bit more on the anterior hip just to try to get that extension, but I'm not going to be stretching the hamstrings. Maybe some soft tissue to help release it. So like manual soft tissue work, or just like have them foam roll or hypervolt or whatever they think feels good. Is there anything that you would do, or what are your thoughts on that?
I don't think I ever really like stretch the hamstring for the purpose of lengthening them. I like the idea of doing soft tissue to see if you can reduce some of the tone and see if that makes a difference. Um, Sometimes, like if I'm looking at a straight leg raise and they're just bilaterally poor, and I'll just say like, are you always this tight? Is this how it's been? A lot of people like, oh, everyone says they have tight hamstrings, I feel like, but some people, they're like, yeah, I've always been this tight. I've never been able to do this. Or if I haven't been forward, like this is as far as I've always gone. Then yeah, maybe something to address. I don't know if I would stretch or just do like RDLs, but
Yeah, I was going to say just eccentric loading.
yeah, but I would not focus on that. I would do other things first and see if it needed to be addressed kind of later on. But I think it also depends as like how flexible do their hamstrings need to be to do the activity that bothered them, because if they don't need to be, if you're, I don't know, whatever the sport may be, if you don't have to have the most flexible hamstrings, then that probably wasn't the cause of your injury in the first place. But yeah, I think anterior hip is probably more approachable with that. Is there anything else that I have a couple like curveballs that I read that were interesting, but is there anything else that just off the basis of history, exam, and treatment that you would do for low back pain, particularly extension based, like we've been talking about?
I think the biggest thing, we can get the biggest bang for our buck, and that's subjective. So just making sure that we're checking for any changes. So any change in sport, loading, repetitive activity, just those big things that pop up, because that's going to give us our biggest cue. Likely these aren't things that are these aren't as acute. These are more of just these things gradually build up over time. So there's not going to be one specific mechanism of injury that leads to this. It's going to be something, like we said, that's repetitive loading where that bone isn't able to remodel. But I think just making sure that you're aware of it. I know during residency, we didn't see a lot of this because they're college athletes, so it's applicable in college athletes, but it wasn't until I got to Apex in Columbia where we were seeing they had like a pediatric sports side and adult sports side, and we would see some of those youth athletes. That's where it really popped up on my radar, and had to be a lot more conscious of it with a lot of these middle school and younger high school kids. So just knowing the prevalence and the signs and symptoms to look out for, because it's not too hard to test for. It's just making sure that you're aware of it.
Yeah, no, I think that's perfect. I think, well, like we found with almost everything, the subjective is probably the most important. I want to talk about two things that I read, and then if we don't have anything else, we can wrap it up. And you might like this one, though hard to use because most places don't have it. There was a study that was with football players with chronic low back pain. It came out in 2020, and it compared isokinetic back training to core stabilization, and then to a control group. And they looked at pain intensity, player wellness, and a 40-meter sprint, a 4x5 meter sprint, submax shuttle, and then a counter movement jump and a squat jump. So I just want to go through this and get your thoughts on it because I thought it was pretty interesting. Have you seen this paper?
I have not.
Okay. So it was 60, they had 60 players. They were divided up into 3 groups of 20. They did their baseline measurements of all those things that I just spoke on. And they did 4 weeks of exercise, whether they're in the isokinetic, core stave, or control group. The isokinetic protocol, they had them move from 10 degrees into extension to 80 degrees of flexion at angular speeds of 60, 90, and 120 degrees per second. They did 3 sets of 15 with 30-second rest between sets and 60-second rest between the different paces. And they did that 5 days a week. For the core stave, it was slightly confusing on how they said this, but they did a lot of exercise with the Swiss ball. They also did supine bridge, sit up, kind of arms, legs, cross lift, just like a prone swimmer sort of thing. And side bridge, they did 3 rounds of 10. They maintained the positions for 10 seconds with a 3-second break in between reps. And they did that 5 days a week. Then the control protocol just did active isotonic and isometric exercises for the abs and back. That was 10 to 15 reps a day, 5 days a week. And they also stretched each muscle group 3 reps for 10 seconds, being the hamstring, hip flexion, and lumbar extensors. They gave all subjects the same home exercise program, and all subjects also underwent 20 minutes with a hot pack and 5 minutes of ultrasound, which neither here nor there. Probably could have left that out. But the results based on in all categories, pain and player wellness, their sprint capacity and performance, and their jump performance, the isokinetic training group improved the most. They all improved, but it's isokinetic training improved the most, then core stave, and then control. Have you ever thought about isokinetic training for low back pain?
I have not. So if I'm picturing that right, that's pretty much just the setup like you would see at a normal Globo gym where someone's sitting on a back extension machine, right? And just kind of leaning backwards like a reverse curl up. Is that pretty much the setup?
Yeah, in from like 80 degrees of flexion back into about, I guess, 10 degrees of hyperextension at different speeds.
Yeah. I like the idea. I would rather do a reverse hyper, but I mean,
you can't do it.
No.
No one, people are trying to get isokinetic machines just for like ACL purposes. So I just thought it was interesting. I was like, it's a super weird study and definitely not practical for 99.9% of PTs. But interesting, particularly when we talk about the difference between getting very specific with some of this stuff versus not. And it kind of builds on your idea for the source and holds, just getting like the whole posterior chain working is probably helpful. So I thought that was interesting. And then the other thing I wanted to talk about was a case study that was the rehab of a young athlete with extension-based low back pain, addressing motor control impairments and central sensitization. I don't want to dive too much into this because we're going to be talking about some of this next podcast, but came out in 2018. It's a 15-year-old gymnast with a 4-year history of extension-based low back pain. There was a healed spondy. They noted some fatty infiltrate and atrophy in the lumbar multifidi. Despite the healing, the patient was calling her low back pain the fracture in my back. So there was obviously some psychological issues there, with I guess how that was framed. But the big thing I wanted to point out was she had been to PT before, and they focused on core strength without long-lasting improvement. So thinking of like a general core stabilization program. And the difference with this is they focused on dysfunctional movement. So they noticed she had early/excessive lumbar extension when leaning backwards. I don't necessarily know how you would classify that. That's what they called it. They noted some hip flexor tightness, quad tightness, mid-thoracic stiffness, and limited ankle dorsiflexion. So based on what she would need to do for her sport, they made sure that she could control her spine with those movements, that excessive lumbar extension, which is what they're going to be doing a lot of, they worked on the regional interdependence model of working on their dorsiflexion, working on her thoracic stiffness, and working on her muscle tightness via different manual therapy techniques and stretching. And then the central sensitization piece, they worked on graded exposure to desensitize and reduce fear. So I think sometimes, though, some of the papers that we've read have spoke a lot about, and they're older, but spoke a lot about like specific strength into the TA and the multifidi. Some papers say that that is better than just general exercise. But I just think it applies to different people. And if there's someone that has like that baseball player, that gymnast that has a particular movement that they aren't performing correctly, and it's obvious it is placing stress on the lumbar spine, then you have to diagnose that based on the whole body and then treat it appropriately. And you'll probably see better results than having them just focus on like the drawing and maneuver.
Yeah, definitely. No, I love that. I'm a big fan of that, treating the impairments, treating the whole body. But going back to that, what you were saying about the isokinetic, I think it's just about loading, because we definitely don't load patients enough, especially their lower back, right? We think that planks and all that are loading the lower back or the core. I don't think that provides enough of a stimulus. So something to where we can progressively load lumbar extensors or lower back is going to be helpful. I know that's something that's really helped me in the past couple of years, getting a lot more focused on that versus just your general core stability. So getting a stronger back, I think, is going to be a lot of the thing too, just progressively loading and getting them stronger, more resilient, all those types of things.
No, I agree. And I don't want to ramble on here, but quick question. So I know you said with like the back extension, whatever, you tell them to squeeze their butt. Do you ever have any issues with just having them do it, whether they're using their kind of more erectors as opposed to their glutes, like just to target the low back? Like, because sometimes, yeah, I'll have a patient, if I'm working on maybe getting them to be able to like work their glutes appropriately, I'll put them in there and have them contract their glutes as they come up. But other times, if I have a patient that just has low back pain, I'll have them do back extensions and just say, come up, just because I'm trying to load their low back in whatever way gravity is going to make them load their low back.
Yeah, I mean, that's interesting. I mean, you could do an EKG study on that or an EMG study and see what the muscle activity is. But yeah,
I don't really care like what
see
muscles
what
are
happens.
working. Yeah, I just know that like their back probably could be stronger, and if I put their low back in a position where gravity is pushing down on them and they have to come out of it, it's probably going to work their low back. Yeah, you'll get glutes, you'll probably get hamstrings too. But if I have them focus, like I almost want them, you know how when you deadlift a lot, you start to feel like you get a pump in your low back because you're getting fatigued, you're not using your glutes quite as much. Like I almost want them to have that. Like get a pump in your spine, erector spine is, because I think that, like, I don't know, your paraspinals, I think that is working your back, which is the same thing as a source and hold or that isokinetic machine.
Yeah, I'm all for that. I like that a lot. Yeah.
But
yeah, go ahead.
What were you going to say? Because I was going to wrap it up.
I like that. Just feeling that pump. There's studies that actually show that internal focus with like bodybuilders that focus on their biceps when they're doing a bicep curl versus lifters who don't focus on that, their biceps get bigger. So just having that internal focus. Yeah. I want that feeling in my lower back. I mean, could help the muscle grow. Who knows?
Yeah. It's like if I'm working on foot strength, I'm going to try to get their arch fired up a little bit. It's like when we were talking about doing planks, like squeeze your butt, squeeze your core, like focus on it. An athlete should be able to tell their body to do what they want it to do. Like even just having the control, whether it's not necessarily important for the movement, but that they can actually do it is important, I think, for that population.
And generally speaking, they have a little bit more body awareness. So they're able to feel and get into those positions and know what they're doing. So yeah, no, I agree. Hopefully people enjoy that and it's not offending some of the focused TA and multifidi groups, but
everyone has their opinions, but I don't think there's necessarily a wrong way, because exercise is always good. It's just maybe different ways to do it. But yeah, I think that is good. I think we covered everything we wanted to cover. You want to go ahead and close it
Yeah, so thanks everyone for listening again. This is our 10th episode, and be on the lookout for a new episode in the next couple of weeks regarding pain. So Josh is going to be our pain specialist, and we're going to grill him and learn all things about pain. So be on the lookout for that in the next couple of weeks. If you guys have any questions, make sure to reach out to us on social media or our website.
All right, thanks for listening.
Thanks for listening to the Athletes Performance Podcast. If you have any questions regarding this episode or future episodes, please be sure to reach out on social media or our website.